Hello, I'm Dr. John Cruz. I'm the author of Recognizing Adult ADHD, What Donald Trump Can Teach Us About Attention Deficit Hyperactivity Disorder. And today I'm going to be talking about armchair diagnosis of ADHD and whether that's a good idea, bad idea, and what we can learn from it. I'll be talking for about 20 minutes, and you're welcome to write in questions while I'm talking. This will be posted both on Facebook after this presentation, and in days to weeks will be also on YouTube. So I'm going to launch into it. We use the term armchair quarterback or armchair critic to refer to someone who may know a lot intellectually about a specific subject, but actually has no practical experience or genuine understanding of it. So it's used as a criticism of those who are watching a football game and thinking they know more than the quarterback or would have thrown to a more appropriate player or made a more wise pass or series of plays to score a goal. And the interesting thing of using that as a criticism is that one is that people are often not criticizing or saying that the assessments are inaccurate, that they're more that they are being presumptuous. So I'd say if someone accuses me of making an armchair diagnosis, the label doesn't actually really fit because not only do I know a fair amount intellectually about the subjects, but my experience is day-to-day working on diagnosing and treating people. So I believe I do have an understanding. So it seems odd, as I've been charged mostly by people on the right who think I shouldn't be saying anything other than that Trump is a godlike figure, that I am not doing something I don't normally do, and I do have experience and understanding. But so specifically, they would claim that in this situation, you don't have all the inside information. So just as, again, the armchair quarterbacker may actually see which players are open because they have different camera views and different angles. They may actually have more information than the quarterback does, but they're missing information on the ground that the quarterback may know that this guy, had too much chili for lunch and is sluggish and, not going to be quick on the uptake, or that this person's finger was injured in last week's game and we haven't made that note, our opponents, we're not going to tell them about, but the quarterback may have inside knowledge both in the moment and in the history of the people he's playing with that isn't there privy to the person watching on the outside. So the heart of what I'm going to be talking about today is whether the one-on-one evaluation, which has been considered for decades to be the gold standard for psychiatric evaluation in terms of coming up with a diagnosis, should that really be the gold standard, or should it not? And I would argue increasingly not, and I'd say particularly for ADHD, no. So one of the places where the importance or the consideration, and not even really the exploration, but just the assumption that the one-on-one in-person interview is the gold standard, comes into place in the American Psychiatric Association's Goldwater Rule, which is part of its ethical standards for psychiatry, where they say that a psychiatrist should not be making public pronouncements on a political figure without a one-on-one evaluation and that person's consent. And I've talked more on the Goldwater Rule on another talk on this series, so I won't go much more into it now, but I'll back up and say that historically, psychiatry is on two different tracks. We have the Goldwater Rule, we have this claim of a one-on-one evaluation being our gold standard, and yet the holy grail for psychiatry for the last 50, 60 years has been a search for biomarkers. Get a blood test for depression, maybe the dexamethasone suppression test. Dexamethasone is one of the drugs Trump was treated with for his COVID 2 weeks ago. Maybe that will be a irrefutable biological marker that someone has depression. We've been looking for genetic markers. We've been looking for patterns on EKG scans. We've been looking on brain imagery. We've been looking at, the size of certain parts of the brain. We've been looking at blood tests to see if there's biochemical markers. We've been looking at connectivity patterns and network issues in the brain to see if there is some definitive marker where we can identify who has depression and who doesn't, or who has ADHD or who doesn't, or who has dementia, or even more interestingly, who's going to get dementia 10 years from now. All of this emphasis, if it came to fruition, would actually obviate the need for the one-on-one evaluation. If you can determine from a blood test that someone's really depressed, why sit down for 2 hours if the goal is just to determine whether they're depressed? Again, I will say that there is certainly huge value in a one-on-one interview to get to understand the person as an individual, to know the context, to know more than just a diagnostic assessment. But in terms of purely, we're talking here in terms of diagnosis, psychiatry at one hand is working to get rid of the need for the one-on-one interview, at the same time exalting it as the standard. I will say that right now we don't have any biomarkers that have turned out to be clear-cut indicators of a certain diagnosis. You may argue that we have a gene for Huntington's chorea, and Huntington is both a behavioral, neurologic, and a psychiatric disorder. But there aren't too many other conditions where I can point at. That doesn't mean we haven't in many cases found group averages between the size of the putamen or the activity in the hippocampus or other markers where there are group differences, but in all the situations so far, the quote normal groups overlap, even if the averages are markedly different, so those are not useful for biomarkers. I mean, part of why psychiatry is so invested in this is that this is a psychiatry for decades has been the gatekeeper of deciding who has a certain diagnosis or condition. And gatekeeper in two senses, that we are both the ones writing the definitions in our official diagnostic and statistical manual, and we are the ones who by and large are considered the experts at deciding who fits those criteria. And other, in general, mental health practitioners defer to us as those decision makers. I think part of why psychiatry is so invested in not changing things is that they fear the loss of that role could be damaging to the field, but jumping into it. So how good is a clinical interview, this gold standard? And one of the things is we have a wealth of data that show that, actually, so I'll back off a half step. So one of the purported values of this one-on-one interview with the person you're examining is that you will be able to sort through and get to the root of the motivation. So rather than just sort of the superficial dross of behavior or language or claims, the claim here is that the one-on-one interview will allow you to elucidate some inner meanings, some inner patterns, the motivations, the true source of why the person's behaving in a certain way. And particularly with the issue of public officials, it's that you will be able to get behind the mask that this person's presenting to the public, and that could be true for both a private citizen and a public figure, but you will be able to sort through some pathologies, some motivations, some origins for what they're doing behind what they want to be revealed. So the data, though, is not very convincing for this. So particularly, and here it's important to differentiate between the standard approach for an evaluation is what's called an unstructured interview, where the examiner asks questions of the interviewee, so the doctor asking questions of the patient, and that's proceeding for an hour or two to try to elucidate the source of problems the person's having in their life or is causing other people in their lives. We know that the one-on-one interview, in an unstructured interview, even with very experienced clinicians, does not show particularly good validity or good reliability. And that means two different experts interviewing the same person. And it depends on the diagnosis. It depends certainly on that individual as well. But there is not particularly great concordance. Now we know that we can improve concordance, we can improve reliability through structured examinations where you go through a specific set of questions and depending on the answer, you follow up more intensively. Even there, though, the concordance is not perfect. So there is a lot of sloppiness and inaccuracies in what we consider our gold standard. So many of our diagnoses are based on the person displaying these traits, whether it's depression, where you need to be depressed for predominantly for 2 months at several weeks at a time, or patterns of, a manic episode requires a certain number of days, at least a week of manic symptoms. Personality disorders require much more pervasive across a variety of situations and persistence across time. So how the heck are you going to figure out in 1 hour of interviewing, other than accepting that everything the patient says is valid and good, whether someone is actually displaying those symptoms, traits, behaviors, patterns? You simply do not have that information from a 1 hour interview. You can accept what the person's saying, or again, with public officials, public people like Donald Trump, where we have weeks and weeks, months and months of data, behavioral data, where they are behaving in a variety of different situations. We can have them, and over a number of years, it's not just the sheer amount of data, it's the diversity here. It's that you can show pervasiveness. And again, this isn't just true for ADHD, it would be true for narcissism. I mean, narcissism doesn't involve just being self-centeredly oblivious of someone else's needs in one specific instance or interaction. It's pervasive pattern over time and in a variety of situations and with a variety of people. Again, I can't hear any valid argument that in a few hours of one-on-one interview, you have a better insight into pervasiveness or persistence than you can get from culling the data of public officials where we have hours of recorded videotape of them behaving over time. So that's an area clearly the one-on-one gold standard is inferior to culling data from the public domain. A third point about that is that, again, the claim that if you have the person in your own office, then you can more pointedly get to ask them about their motivations, ask them about their thinking, ask them about what was the precursor or what they were feeling inside when they said X, Y, or Z, so that you can get a more in-depth, insightful view of what's driving particular answers to questions or performances in the public. The difficulty with that is that the interview situation is a highly artificial one, and it is a performance piece. So this is not just true if Donald Trump came into your office and you were tasked with evaluating whether he's really a narcissist or evaluating whether he really has ADHD. He'd be performing with his own intent of whether he wanted to convince you that he had those or whether he was trying to convince you that he was not. But that's true of the general population. Anyone coming in just for help with their problem knows at some level that this is a performance they are engaged in. There is an artificiality to the interview setting, which distorts some of the information you're getting or not getting. They are, whether consciously or not, the person presenting to you is either holding back information or emphasizing certain information or embarrassed that they've forgotten certain information or has come in with a list to make sure they got these certain points deleted. So they are coming in with an agenda, and that is therefore biasing the information you're getting in an individual setting, probably at least as much as the information is biased when Trump is speaking to a specific audience to appeal to a certain audience. Again, it's the collection of Trump speaking in a multitude of different settings, including times when he may not be aware that he's being recorded. It's the infamous Access Hollywood tape where he talks about grabbing women's pussies. Again, I would argue we have a much richer, much more likely to be representative, much more ability to triangulate from a lot of different sources what may be going on than the sort of the artificiality of a one-on-one interview, and particularly the artificiality in a if you were to interview a politician when they know that they're being examined. So the fourth area where I'm going to bring into where our clinical interviews are lacking is that there's issues of cognitive bias. And even the most well-analyzed analysts themselves still have blinders, still have scotoma, which are blind spots where they can't see what's going on. They still have their own biases. They are still skewed in their own ways. Some of the patterns that have been discussed, one is something called diagnostic overshadowing. And we see this all the time with Donald Trump. The flashy diagnosis, the narcissistic personality disorder, everyone sees that in him. The ADHD, many of you have ADHD, see it robustly and clearly in Trump, but even when I went to the American Psychiatric Association meeting a year and a half ago, talked to bright, intelligent psychiatrists about my book, Recognizing Adult ADHD, using Trump as an example. Half of them, these are experienced clinicians, these are smart people, these are people who watch the news and listen to him, said, oh my God, you're right, he has that. I've been so sucked in by the narcissism or the other sociopathy, the other personality disorders, I didn't pay any attention. I didn't see the ADD, even though the ADHD is more pervasive. It is there in every action. It is there in terms of how every piece of data he's pulling in or not pulling into his brain and everything that's spewing forth. So diagnostic overshadowing means we pay more attention to the flashier, more dramatic, maybe more interesting diagnoses, and things like ADHD often get overshadowed. The other issue we sort of touched at before in terms of the interview setting is called impression management. The person who you are interviewing is trying to manage what you think of them. One of the interesting studies that's been done is looking at psychopaths. Again, this is not purely a clinical situation. This is not necessarily politics, but psychopaths appearing before a parole board. The parole board are professionals who are trained to interview, examine these individuals to see if they are safe to be released to society, if they really are repentant for their crimes and can be set free. And a study that was done showed that psychopaths, at least the people who are least trustworthy, who you least want to be released out in the streets, were more than 2 times, I think 2.5 times more likely than non-psychopaths to be released. And it turns out, not surprisingly, they went on to have many more recidivist acts and wind up back in jail. So again, even professionals that are trained to evaluate or think that they know what they're evaluating were not a good match for skilled impression management people, the criminals here who were able to effectively hide what they were really, what the real motivations or thoughts were. And that gets to a bigger issue in terms of lie detection. And there was early work by Paul Ekman, who did a lot of work on emotions, facial recognition of emotions. And in his early studies, he looked at how good people were at lie detection. Most of us are pretty lousy. If someone's a paid actor is told to tell you a story, and half the time is lying, half the time telling the truth, our likelihood of knowing which of the lies, which of the truths are about 50-50. And even people who are trained interactors sort of evaluating, so judges, he did his tests with judges, he did his tests with therapists, he did his test with the police, he did his test with teachers, he did his test on parents, and all were about 50% accuracy. People are not very good at detecting lies in other people. The one group that he had that did better were social Secret Service agents. And that was revelatory in terms of the Secret Service agents weren't necessarily trying to follow some of the other aspects of language or body that we conventionally think may reveal a lie. They were more attuned to actually intricacies and little movements of face, hands, body that were inconsistent and might belie a lie. I won't get into lie detection further, but it highlights, I mean, another example where human observers are not very good at observing, particularly when in the moment. And one of the other big examples of that is we have so much data that eyewitnesses to crimes are a horrible source of information in terms of specifically identifying who the criminal is. It doesn't mean they're always wrong, but the person's sense that Yes, that's exactly the culprit. I saw them do it. We know that their own faith in their accuracy is not a good indication of their accuracy. And we know that a huge embarrassing for our legal justice system percentage of the time, the eyewitness is not inaccurate. They've misidentified who did it. And we are all humans, so we are all making mistakes in evaluations. Again, if you're in a one-on-one evaluation, you are likely to be making some of these cognitive biases. When you have the ability to step back and again look at a wealth of data, I would argue you are more likely to make an accurate diagnosis. And again, as I've talked before, for ADHD, the diagnosis is a purely descriptive, purely behavioral one. The data's out there, we should be using it. And I'm not saying, again, the average citizen, we don't have hours of video to look at and examine, but we do for public officials. So calling it armchair diagnosis as if it's being made flippantly is actually, I think, asked backwards in terms of the person stepping back, collecting this vast body of data, has more insight, more awareness of patterns, of pervasiveness, of the criteria we actually measure ADHD by. So that is the end of what I'm saying today. Next week's session, I'm going to be talking about amphetamine-induced psychosis. And be safe, have a good week, and don't let either COVID or concern of politics overwhelm your brain and body in the next week. That's all.